Recording in progress.
All right, good night or good evening. Say good night, everyone. Good evening, everyone. Tonight we're focusing on kind of getting us ready for the cumulative review as well as covering chapters 14 and 15. I also want to remind you that you will be getting a Moodle message just to remind you about next week's schedule. Remember that Tuesdays classes will be recorded and then Wednesday classes will be scheduled for Monday, regular time. I know a message was sent back a couple weeks ago, but I want to just remind you, and I'll remind you again next week as well. Okay. Now, tonight, though, this session is really designed to help you consolidate key pharmacology concepts that support safe surgical practice and that you may see coming up really soon. Now, we've talked a lot about how medications interact with body systems, how anesthetic agents affect physiology, how those changes influence what happens in the operating room. Tonight is about kind of like bringing those ideas together so we can approach the final exam with confidence. Okay. Now, again, reminder, we as CSTs are not administering anesthetic drugs, right? But it is important for us to understand how those medications affect the patient, and it helps us to anticipate what happens during the actual procedure. For example, changes in respiration, blood pressure, muscle relaxation can influence how those medications affect the patient. It also gives us time to prepare and respond. That's going to really help as you guys get ready to go into the lab next module. So, with that, let's talk about our quote of the week. Success is not or is no accident. It is hard work, perseverance, learning, studying, and most of all, love of what you are doing or learning to do. Now, this particular quote reminds us in any professional field, especially healthcare, it's built through consistent efforts and commitment. Over the course of this module, you spent time learning about pharmacology, anesthesia, and the physiological responses that occur during surgical procedures. These topics can be very complex and they require careful study and attention. Now, the effort you've invested in understanding these concepts is part of what prepares you to function safely within your surgical teams. As you guys get ready for this exam, remember that preparation and persistence play an important role. I'm going to be giving you some ideas of some misconceptions that or misconcepts that have creeped up in the past. Okay. I also want you to think about this as we go through tonight's course. Looking back at the material that you've already covered, which concept or topic required the most effort for you to kind of understand? Reflecting on that can actually help guide your final review. Okay. I see meds, I see instruments. Now, let's talk about why this material matters beyond just this exam. Because keep in mind, you guys are about to be in lab and then you're going to be in the clinical setting. As a CST, you guys already know that you are a part of what is called the safety net of the operating room. While anesthesia is responsible for monitoring the patient's psychological or physiologic status, we play an important role in maintaining our sterile fields, right? We're anticipating what the surgical team needs. You'll notice the sequence here: normal, abnormal, action. In clinical practice, the team constantly observes what is going on with the patient. When even just a small thing shifts from normal to abnormal, we have to quickly interpret what the changes mean and respond appropriately. Understanding pharmacology and anesthesia is going to help you to recognize when something may be changing. Now, one of the most important skills in the operating room is anticipation. I talk about it a lot. That muscle memory, I promise you, is going to kick in. That means that you're going to be recognizing patterns. You're going to be understanding what the surgeon, anesthesia providers are doing. You want to be so in tune with your team that it's a well-oiled machine, like a beautiful dance. Okay. So that means preparing for what you will be needed next. This awareness helps the entire surgical team function smoothly and safely. Now, the quote at the bottom captures this idea, okay? You guard the field while anesthesia guards the life. To do that, you must kind of speak their language. What this means is that understanding anesthesia terminology and physiological responses help you to communicate effectively with the rest of the surgical team. When we're like all on the same page, we can respond more quickly and effectively to changes in the patient's condition. Now, let's step back for a moment and look at anesthesia from a big picture perspective. When we talk about general anesthesia, we're talking about achieving 4 primary goals that you may see in this week's quiz. You'll see them listed across the top of the slide. Okay. We have unconsciousness, which means that the patient is not aware of the procedure. The second is analgesia. This is the absence of pain. The third is amnesia. The patient does not remember the procedure afterwards. And the fourth, immobility, which allows the surgeon to operate without involuntary patient movement. These 4 goals work together to create a controlled environment needed for surgery. Now, I want you to look at the timeline along the bottom of the slide. Anesthesia typically progresses through 5 phases. Preinduction, the patient is prepared and monitored. Induction, process of transitioning the patient from being awake to being anesthetized. Make sure you understand the 5 phases and the 4 goals. After induction is maintenance. This is where the anesthesia provider keeps the patient kind of like in a stable, anesthetized state during the procedure. We have emergence. This is when your surgeon passes that resident the closing stitch. And you'll notice that anesthesia will start to reduce the medications to allow the patient to begin to regain consciousness. And finally, recovery. This is where the patient continues to stabilize following anesthesia. For your exam purposes, it'll be helpful to kind of think about these phases as a timeline. Induction is essentially going to sleep. Maintenance is keeping them asleep. And emergence is waking them up. That distinction is going to help clarify many anesthesia related questions. Hint, hint. Okay. Many anesthesia related questions. So if a patient is starting to show signs of movement or awareness during surgery, I want you to be thinking about which phase of anesthesia might the team need to reassess. Once you start putting these type of questions in your head, and then looking at your questions, it'll help you to differentiate. This is where we are. And I love it. Someone already put an answer. Now we're cooking. So we've got the goals. We've got the phases. But how do we get there? We have to talk about airway management. When anesthesia is induced, one of the first priorities for the anesthesia provider is ensuring that the patient's airway remains open and that ventilation can be maintained. If the airway is not secured, oxygen cannot reach the lungs and the patient's safety is immediately at risk. One device that is in the chapter talks about the laryngeal mask airway, or the LMA. This device kind of sits above the vocal cords and helps maintain an open airway without entering the trachea. It's often used in procedures where full endotracheal tubing may not necessarily be necessary. Like the patient's not going to be under that long, so an LMA is fine. Okay. But let's say we do need to do an ET tube or endotracheal tube, where now it's inserted through the vocal cords and into the trachea. The method provides a more secure airway and it allows for controlled ventilation during, let's say, your longer cases. I want you to think of like maybe a cranie or a total hip, a big belly case, okay, or more complex procedures. It also helps, or heart, right? Heart's another one. It also helps protect the airway from aspiration, okay? Now, on the right side, you'll see what's called the Silic maneuver, also known as cricoid pressure. Sometimes in the operating room, if you are remember scope of practice though, but you may be a free person and the anesthesia may say, give me a little cricoid pressure. And that's exactly what you're kind of doing. You're just putting pressure on the cricoid cartilage, and it really helps to kind of compress the esophagus and reduce the risk of stomach contents kind of like moving upwards during the rapid sequence of induction, because remember, you still have that gag reflex, so you're just trying to help anesthesia out a little bit to kind of bypass that. Okay, now again, this technique is used to help prevent gastric aspiration. Make sure you understand cricoid cartilage, aka Silic maneuver. Okay. One detail students confuse is the difference between cricoid cartilage and thyroid cartilage. Now, the structures are located kind of close together, but the Silic maneuver, i.e., cricoid pressure, specifically involves pressure on that cricoid cartilage. Okay. Being able to kind of recognize that distinction is going to help confusion during the exams and, once you guys get in the clinicals as well. Now, the sleep switch. We're going to talk about medications that actually start the anesthesia process. These drugs are called induction agents. They are used to transition the patient from being awake to being unconscious. You'll sometimes hear anesthesia providers refer to this the moment of, okay, patient's going to sleep. Okay. The medication does work very quickly. Have you ever seen those videos where you'll have someone who they're like, I'm going to beat anesthesia, and they try to count to 100 and they're usually asleep by 4, right? It's usually within about a minute. Maybe it's like that fast. Okay. So we have Propofol. This is the first drug that you see. It's also known by the brand name Dipravivin. So you may see Dipravivin, but you've heard Propofol before, okay? And that's because this is one of the most commonly used induction agents. It produces rapid unconsciousness and is often preferred because patients typically wake up quickly once the medication has been stopped. One important critical consideration is that propofol formulations may contain soy or egg components. So anesthesia providers really are going to be looking to see if a patient has any allergies before they give propofol. Now, ethmodite is chosen for patients who can't really tolerate propofol or tolerate drops in blood pressure. Okay. So let's say the patient experiencing a trauma or hypovolemia, that they may receive this particular drug because it tends to kind of like maintain cardiovascular stability. And then there's ketamine. This is the third drug, which works just a little bit different. So ketamine produces what's called a dissociative state. The patient may appear awake or may even have their eyes open, but they are not aware of their surroundings or experiencing pain in like the usual way. Now, this drug is used in trauma settings or situations where maintaining airway reflexes is really beneficial. Okay. But something that I want to kind of have you guys remember for the exam, and it's the bottom line here. These medications produce unconsciousness. They do not provide muscle relaxation. That means that another medication has to be given with these to kind of complete that muscle relaxation. So we have gone through the goals, the phases. We know what we're going to use to put the patient or to get the patient induced. And we looked at the medication to have them go from awake to unconscious. But remember, this doesn't have anything to do with the muscles. So we get to the neuromuscular blockers or the paralysis switch. These drugs are neuromuscular blockers, and their role is to produce paralysis of skeletal muscles. It's especially important for procedures where the surgeon needs the body to kind of remain completely still, especially if we're doing like a spinal case. We do not want the patient to have a lot of mobility when we're around the spinal cord or the brain or the heart or the lungs. Okay. It also helps anesthesia providers safely place an endotracheal tube because the patient will be relaxed and they don't have to also worry about patient going into laryngospasm or anything crazy like that. But I want you to remember this. Neuromuscular blockers do not cause unconsciousness and they do not relieve pain. Keep that in mind. They do not relieve pain. They only stop the muscles from moving. If you've seen that movie Unconscious with I think Jennifer what's her name? The girl from Honey, and her boyfriend or a husband, I forgot who he was. He was undergoing surgery at the movie was Awake. So in Awake, he was paralyzed but could feel everything. Okay, granted it's a movie, it's Hollywood, but it kind of like makes you think. Now, this is why like these particular drugs are given after sedation or during the induction agents. So some of the drugs you'll hear succinylcholine. All right. On the left side, it is the most common depolarizing neuromuscular blocker. You're going to hear sucks a lot. Okay. The drug works by mimicking the neurotransmitter that's responsible for that muscle contraction. I agree, it was a good movie. We're talking about Awake again. If you haven't seen it, check it out. Now, when we look at these mimicking neurotransmitter drugs, at first, the cause is like a brief muscle twitch known as fasciculations. Okay. After the short period of twitching, the muscles become paralyzed. One important safety note is that sucks can trigger malignant hypothermia in susceptible patients. The thing about malignant hypothermia is you don't know the patient has malignant hypothermia until they get malignant hypothermia. Okay, so also keep that in mind. For non-depolarizing blockers, such as rocuronium or vacronium, these drugs work slightly different. Instead of mimicking neurotransmitter blockers, they block the receptors from binding. So it prevents muscle contraction entirely. So whereas the one will paralyze it, it'll twitch first and then paralyze it, this kind of cuts off that before it can even do that. Okay. Now, these medications can also be reversed, often with agents such as neostigmine combined with atropine. And they'll have that on board just in case or around them. If you remember only one thing from this particular slide, remember the exam clue at the bottom. Facilitation are strongly associated with sucks. Okay. That clue often appears, especially when you get close to your certification exams. So let me ask you guys, if a patient receives a neuromuscular blocker but no sedation, what might the patient experience? I want you to consider what it would feel like to be unable to move while still conscious. Most definitely, they're going to feel pain and fear, right? Like you can't move, but you're, and anxiety, most definitely. Exactly. You're going to be scared because you can't do anything, but you're feeling everything, right? Now, this is why anesthesia must carefully kind of coordinate with a lot of these medications. I don't even know if it's numb because they can feel, but they can't move. It's like imagine being strapped down with no straps. Like you're trying to move your muscles, but you can't, but then you feel pain, right? I don't want to experience that. But um we have to talk about malignant hypothermia because I have seen a couple questions on your couple concepts dealing with malignant hypothermia from not only just this week, but that you may see next week as well. Now, this condition is a genetic disorder of skeletal muscle metabolism. It occurs when certain anesthesia drugs, usually sucks, trigger an uncontrolled release of calcium inside muscle cells. The process causes rapid muscle contraction and extreme metabolic activity, which can become life threatening very quickly. One of the most important things to remember for exams is the trigger combination. The two major triggers are sucks and volatile inhalation anesthetics. When a patient with malignant hypothermia susceptibility is exposed to these agents, the reaction can escalate so fast. So, here's some of the early signs. And this particular concept I've seen missed, so I'm going to try to like break it down. Something extremely important to recognize is that people often think that fever is the first sign of malignant hypothermia. I have seen this concept, and that's one that sometimes gets marked. It is not. Write this down, mark it, try to visualize it when you see a malignant hypothermia. The earliest indicator is a rapid increase in end-tidal CO2. So you'll see EtCO2 or end-tidal CO2. I'm going to repeat it 3 times. End-tidal CO2, end-tidal CO2, end-tidal CO2. Okay? Earliest indicator. On monitoring equipment, you may see the CO2 level climbing, even though everything seems normal, everything seems adequate. You may also observe muscle rigidity. Maybe the jaw muscles are kind of tightening up, and that's known as masseter muscle rigidity. Let's see. Now, all of these are early signs that the body's metabolism is starting to accelerate dramatically. But again, the earliest indicator, one of the first signs, is that rapid increase in EtCO2, in tidal CO2. Now, the late sign is interesting because the symptom many people associate with malignant hypothermia is very high body temperature, but that is a late sign. It happens later in the process, and that's why I really wanted to break that down. That's why the emphasis, do not wait for fever to diagnose malignant hypothermia, because at this point it's one of the later stages, or one of the later stages of malignant hypothermia. By the time the temperature rises dramatically, the crisis may already be advanced. So I want you to think about this scenario. You're in the operating room, and the anesthesia monitor certainly shows a rapid rising. Like you're looking at the monitor and you're like, wait, the end-tidal CO2 levels are going up a little bit faster, a little bit higher than they should be, but the patient's still breathing normally. What should that pattern make the team start thinking about? What could be going on with our patient? Looking at the monitor, CO2's rising. Exactly. Malignant hypothermia. That is what we're trying to look at. We're thinking like, oh, okay, what's going on? We're going to get that malignant hypothermia cart. And one of the first medications that are going to be given is going to be dantrolene. Now, recognizing those clues really does make a difference between a manageable emergency and a critical crisis. Now, because malignant hypothermia progresses so quickly, early recognition and immediate intervention are going to be really important for our patient's survival. Now, I kind of talked about the drug already, but it gets instilled into your brain. You have that muscle memory. Now, once malignant hypothermia is suspected, like we're thinking, we looked at the monitor, we already said it. Oh my goodness, it looks like malignant hypothermia. The most important thing to understand is that timing matters. This is not a situation where we're trying to wait to confirm, right? Instead, in the operating room, immediately we begin emergency malignant management or malignant hypothermia management protocols. One way to remember the major response steps is the acronym on the slide, HDSTDI. We hyperventilate. The first step is hyperventilation with 100% oxygen. This is going to help reduce carbon dioxide levels and support oxygen delivery during the hypermetabolic state. Remember that malignant hypothermia causes the body's metabolism to just start accelerating dramatically. And that's why you want to increase the oxygen demand and looking at that CO2 production. I mentioned it already, but dantrolene. The next step is dantrolene, which is the specific antidote used to treat malignant hypothermia. This medication works by kind of just going in and reducing the calcium release within the muscle cells. And that's going to help stop the uncontrolled like muscle contractions that are causing or that's driving the crisis. In most facilities, dantrolene is going to be stored in that malignant hypothermia emergency cart. Once you guys get to your facilities, that's going to be one of the first carts you learn where it's at, kind of next to the code cart. Okay. We also have sodium bicarbonate. That's the next intervention. It helps correct metabolic acidosis. Now, because the body's metabolism has like increased, acid levels in the body can quickly rise. We also want to do temperature control. So we're cooling the patient, which is another important step. You may have cooling blankets brought in, cold IV fluids, or your facility may have other cooling techniques. But the goal is to reduce the dangerously elevated body temperature. Keep in mind, think about that's one of the later signs. Okay. And then diuretics, because now we're trying to help kidney function. When muscle tissue kind of starts to break down, it can release substances like myoglobin that actually damage the kidneys. And then insulin. It may be used to manage electrolyte imbalances, particularly elevated potassium levels. Hyperkalemia can occur during malignant hypothermia, and that can lead to dangerous cardiac arrhythmias. You'll also notice the medication preparation shown on the right side of the slide. Different formulas of dantrolene require different dilution volumes, which is something anesthesia, they're the ones that kind of like calculate during an emergency. So that's not something that we're like, okay, I've got 60 of dantrolene and 5 of, we don't have to worry about that. Okay. Our goal is to make sure that if we're scrubbed in, we protect our field. If we happen to be a runner, we may be responsible for grabbing the MH cart. Okay. Now, if a malignant hypothermia is suspected during surgery, remember that every member of the team, it's important for us to just understand the protocol. Even though anesthesia is the one kind of dealing out the medications, we still have to understand what's going on. Okay. I want to consider how coordinated action affects patient survival in emergency situations. All right. Now, Because these situations can develop quickly, the key is recognizing the pattern of symptoms and really just knowing the first intervention. On the exam and in real practice, the ability to really distinguish between these conditions is going to be really important. Now, I mentioned laryngospasm earlier. This occurs like when the vocal cord suddenly just closes and it prevents air from moving through the airway. One of the classic signs is like a high pitched sound known as stridor, sometimes described as a crowing sound. Okay. Now, when this happens, the initial intervention is just positive pressure ventilation. If the spasm does not resolve, anesthesia may administer succinylcholine, and that's going to relax the muscle and reopen the airway. Another one is a bronchospasm. In this case, the airway is not blocked at the vocal cords, but rather the bronchi constrict within the actual lungs. Here you'll hear like a wheezing sound, okay? Now, treatment typically includes medication like albuterol or epinephrine, and this is similar to what you might see during like an asthma attack. And then at the bottom, we have anaphylaxis, the third emergency, which is a severe allergic reaction. This reaction can occur in response to medications. It could be latex or other substances introduced that in surgery. Okay. One of the earliest signs is sudden hypotension, meaning a rapid like drop in blood pressure. The primary treatment is epinephrine, often followed by antihistamines, known like a Benadryl. Okay, commonly Benadryl is one of them. Now, one way to recognize the information is to associate each condition with a most recognizable sign. Laryngospasm, think of stridor. Bronchospasm, just hear me wheezing. Bronchospasm, wheezing. Anaphylaxis, hypotension. Recognizing the patterns help you to determine the correct intervention. Okay. And then we look at a cardiac arrest, the code blue. You will learn where your code blue card is. In this situation, the patient's heart is no longer pumping effectively, and the entire surgical team must act quickly and in a coordinated manner. Now, while anesthesia and the code team focus on resuscitation and medication management, we still play a critical role, you guys. Now, on the left side, you'll see several medications that may be used during a cardiac arrest. One of the most common administered drugs is epi, which helps stimulate cardiac activity and improve circulation. Another drug you may hear called is amiodarone, which helps life-saving or life-threatening arrhythmias. And in certain situations, you see atropine. Okay. You also see that it's rare, right? But it may be used to help increase heart rate when severe bradycardia is present. Now, these medications are typically administered by anesthesia or the code team itself. Now, the sterile field still matters. The responsibility is to protect the sterile field as much as possible. And sometimes it's going to feel kind of awkward because you're literally moving back your Mayo stand, watching your back table, and watching the field. Like you are staying clear unless otherwise asked to do something. Okay. If the procedure must stop immediately, we may need to pack the wound quickly, keep an account of every sponge, and safely. You may also be asked to provide internal defibrillation paddles. So they'll hand them to you sterilely to give to the surgeon. And let's say you're doing a heart case or open chest. Okay. A lot of times in heart cases. All right. Now, during a crisis, maintaining organization and anticipation is going to help the entire team function just that much more effective. Now, let's pause for a moment and walk through a clinical scenario. Imagine that we're in the operating room during an emergency trauma procedure. Rapid sequence induction has been performed and the anesthesia provider administers succinylcholine. Shortly afterwards, the anesthesiologist reports that the patient's jaw is locked, which is described as mesosteric muscle rigidity. Now, when we see this pattern, it's important to start connecting the pieces. We know that SUX is a depolarizing neuromuscular blocker. We also know that it can be a trigger for MH. The rigidity can be an early warning sign that something serious is developing. The first question asks, what is developing? When you see the combination of succinylcholine, exposure, and muscle rigidity, the anesthesia team immediately begins thinking, okay, this is MH. The second question asks, what gas must be turned off? I have seen concepts asking questions like this. Now, in this situation, the anesthesia team would stop any volatile inhalation anesthetics. Why? Because they are known triggers that can worsen what's already going on. The third question asks, what medication must be prepared? The emergency treatment for malignant hypothermia is, we remember, dantrolene, right? It works by reducing calcium release in muscle cells and helping stop the hypermetabolic process. You may also notice the monitor reading on the side over here. You can, in some cases, see the monitor, just so you guys know, okay? Haha, someone picked up on it. The end-tidal CO2. Heart rate is elevated and it's rising, and the end-tidal CO2 is rising. The temperature is increasing. I know this isn't Celsius, but it's increasing. These physiological clues help confirm that the patient's metabolism is accelerating. Now, if anesthesia team suddenly suspects MH, what might you anticipate the team needing immediately in the operating room that may not be there? I'll give you a hint. The MH carts are not in the room. So, one thing that they may have to go get. Also consider medication, that one of the first medications they're going to grab, that dantrolene, grabbing that MH cart. Okay? And for us, we may simply have to pull our Mayo stand back and stay sterile. Okay? All right. Now, we're getting ready to come up on this cumulative exam. And I want to highlight a few areas where sometimes, or I have seen students commonly mix up concepts, okay? These are what I like to call the trap cards, all right? Now, on exam, the information itself is usually familiar. The challenge is recognizing which situation the question is actually describing. So we have atropine versus adenosine. Let's start with that one. Atropine is typically associated with heart rate support, particularly in cases of severe bradycardia. Andesine, on the other hand, is used to treat supraventricular tachycardia, or SVT. So even though both medications affect the heart, they're used in very different rhythm situations. On exams, look closely at whether the problem describes a slow rhythm or a rapid abnormal rhythm. Okay? Let's look at these center ones right here. Epinephrine for arrest or ephedrine for hypotension. Epinephrine is commonly used with cardiac arrest and severe emergencies. It's a powerful medication. It's used when the heart has stopped or circulation is critically compromised. Ephedrine, however, is more of a supporting blood pressure, especially during anesthesia induced hypotension. One drug is typically for full emergent resuscitation, the other is used to support circulation. Now, this last one is weight based calculation, and you don't really have to remember anything except 2.2. Okay? If a patient is listed in pounds, the first step is always to convert because we do it in kilograms. So you just need to know 2.2. If it's in pounds, you divide by 2.2. If it's in kilograms and you're trying to figure out the pounds, you multiply by 2.2. Okay? Pounds divided, kilograms, multiply. Converting first helps prevent calculation errors. Okay? One helpful strategy during the exam is to kind of pause and ask yourself, is this question testing recognition of the situation, the drug indication, or calculation accuracy? So let's get 10 concepts to kind of master. Okay. Now, of course, you're going to get your study guide. That will be, you'll see it, I want to say Thursday or Friday. So your study guide will be provided. But as we start gearing up for that, I just wanted to put these out here for you. You'll notice that these are not new ideas. They're just core patterns that kind of show up again and again in anesthesia and surgical practice. First concept, remember that cricoid pressure, also known as a Selleck maneuver, used rapid sequence induction to help reduce the risk of aspiration. Okay. We went in detail with MH, one of the most important anesthesia emergencies to recognize. Um, with that, we looked at anaphylaxis, one of the earliest indications that there may be a sudden hypotension happening. And it's really important to be able to identify these changes in critical emergency situations. So, for those of you that are here, I'm going to go ahead and leave this up so you can take a screenshot if you can. And then for those of you that are watching this archive, I would like you to kind of do the same thing because these are going to be some things that you'll be able to take with you, not just for this exam, but especially when it gets into malignant hypothermia and different traumas, especially if you guys are going to be doing trauma cases, that it'll help you just to feel more comfortable. So go ahead and take your screenshots. Now, these key ideas represent the types of patterns and associations that often appear on your cumulative exam. Okay, so that's why I really wanted to just put them in one spot so you can see them. Okay. Now, before we get out of here, I got to give you time for the survey. I truly believe closed mouths do not get fed, and I want to know how we're doing, how we can improve. Okay, so I'm going to give you 5 minutes before we kind of wrap up. For those of you that are watching, please take the time because your voice does matter. Even though I'm not going to have you guys next module, your experience still matters. Your feedback is going to help strengthen this course and students coming behind you. I can guarantee you the students in module 4 are providing feedback for Mrs. Hughes so that when you guys get to her, that you guys will have and see some of those improvements. The key is you guys have lived through this module. You've seen what works and you've experienced where things could be a little bit clearer or a little bit more helpful. Um, and we want to hear from you. So if you have taken it already, thank you. Enjoy your break. And we're going to do this again tomorrow for tomorrow's class, but just so you guys can have an idea, go ahead and I'll be back in about 4 minutes. as the timer gets ready to go off. Um, 12 seconds. We'll just get. We'll just go. We're good. All right. Now, for those of you who are watching the archive, I do have a few questions for you. Now, during this session, we discussed several emergency patterns such as malignant hypothermia, respiratory emergencies, and cardiac arrest. What early sign helps the team recognize the problem? I want you to focus on how we as the CST contribute to anticipation and team response. Also, one theme throughout the review of this session was understanding the why, not just memorizing the what. I want you to explain how understanding the reasoning behind it helps you make safer clinical decisions. And the last question, at the beginning of this live session, we reflected on the quote, "Success is not accidental, it's hard work, perseverance, learning, studying, and most of all, love of what you're doing or learning to do." After completing this module and preparing for the cumulative exam, what study habits or strategies are you planning to use most to study for this cumulative exam? Now, before we finish, I do want to pause for a moment and really look at this slide. Okay. And I say that because you are ready. You've spent weeks learning these medications, these protocols, and the clinical reasoning behind it. You've practiced connecting physiology, pharmacology, and patient safety. The exam is not going to ask you to just memorize random facts. It's going to ask you to think like a CST, to recognize patterns, to anticipate what's happening with the patient, and to understand why the team responds the way it does. You know the drugs, you know the protocols. Now trust the training you've built throughout this module. Now, what questions do you have for me? Okay, if something does come up, know that I'm here. All right. If there is nothing else, I am proud of the work that you've put into this course, y'all. I know that this has not been easy. We've had a lot of changes and you've shown up. So you need to be proud of yourselves. Okay. Um, since there's no more questions for me, you guys have a wonderful rest of your evening. Be on the lookout for that email just to kind of remind you about next week. And I look forward to seeing everyone who can attend tomorrow's live session. Good night, everyone. Okay, I'm going to check on that one because you should have access to it. So let me just see. I may have to reach out to Mrs. Shrooms and just say, hey, can you give them access? And then you guys will hopefully have it. Okay. Thank you for letting me know about that.